So this is a little bit more peds. You know, this is peds infection, and you can spend a lot of time talking about peds infection. So I want to just focus on a couple of them. There's a whole book out there, Pediatric Emergency Medicine. It's like, you know, an inch and a half thick. But once you discover a kid has a fever, you're going down the fever path. We're looking for the source of this thing. So the idea of getting it, the fact that the temperature is there, the temperature is elevated. We do have a temperature. It's 100.4. That's the definition rectally. But it's kind of interesting how many young parents or new parents are very reluctant to, you know, do a rectal temperature. My son, when he had his daughter, I mean, they wouldn't do it, and so they go to all kinds of alternatives. Well, let's do an axillary. Well, you know how accurate that is. Well, yeah, if you have 102 axillary, I'll take it. If you have a normal temperature with an axillary, I'm not going to necessarily buy it at all. So they do these fever strips and all of these alternatives, which are not as good as the real McCoy. So we got to just do a good. We got to get exact because particularly in kids under 3 months, you definitely need to know whether they have a fever or not. And sometimes when they're at home and parents give some antipyretics and they come in to you and they're afebrile, you basically, the literature says that you should take their word that they were febrile at home. Even if the parents say, I felt Johnny and Johnny's head was warm and that's one of the reasons I'm here, literature says take their word for it as being right, especially when obviously they've been messing with Tylenol or ibuprofen. One of the things that the literature is full of is this idea of fever phobia, that in fact a fever is dangerous. We got to treat it. We got to go to the clinician right away because Johnny's got a fever. And one of the things that we do is we can reinforce that fever is important and dangerous by saying, oh my goodness, okay, we're going to give you some Tylenol and ibuprofen both. We're going to alternate these dosages kind of thing. That sends the message that this is kind of serious. I got to treat it. I got to give 2 medicines. I got to make sure I give these medicines on time so I don't mess up giving them. And that sends the message that the American Academy of Pediatrics at least says, don't do it. Don't do it. If you look at the literature on how more effective it is, you can't show that it's any more effective. You can say, well, it just makes sense. When you actually look at all of the studies have been done, that's why the AAPA says, don't do it. It sends the wrong message and is not particularly therapeutic. Anything here? Oh, yeah. So we often think that the height of the fever, if it's 104, that's pretty serious compared to 101. Well, the temperature height does not relate to whether there's a serious cause for this fever or not. Most of the temperatures that are 104, 104 and a half, they're viral. By far, 95% of them are viral. So that's not kind of a monitor of what the cause of this is or how serious the cause is. Another thing that is not a monitor of how serious this cause is whether the temperature was able to be brought down by acetaminophen or ibuprofen. Some people think, well, we got it down, it's probably not a very serious disorder. That's not true either. And there's some emergency departments that, I don't know if you would like to admit that you are in one, where they won't let the kid go out until his temperature or her temperature has reached a certain level. So Johnny comes in with 104. They're not allowed to go out by the nursing rules until the temperature is this. Well, that is totally unsupported by any literature whatsoever. And if anything, you want to get that little bugger out of there and let him go home. You don't want to have him hanging around. This is not a physiology experiment to see whether Tylenol works. It works if you give the right amount. So if you have any one of those rules at your place, just buck it and say, show me why we can't let him go now. I'm comfortable this child has no serious illness, and we're sending him or her home. Try to be as evidence-based as you can. You can be a real pest when you kind of come up with these journal articles that says, well, we've been doing this for a long time, but these 5 papers say it's not right to do that. So it's really about making kids comfortable. I don't know, anybody ever use IV acetaminophen to treat a fever in a kid? Oh, that sounds like it's pretty commando, if anything, you know. Are they vomiting? Is that what the issue is? Well, that might be one indication, but there's no indication to bring it down rapidly anyway, so I wouldn't know why you would ever give acetaminophen IV for a fever in a kid. It costs the hospital $35 a gram for that stuff. It's expensive. You know, if you give Tylenol, you Motrin, that doesn't cost anything. The hospital will charge a lot for it, but in this case, the charge to the hospital is $35 a gram for IV acetaminophen. So don't think it makes any much sense to give that. You know, some people say, well, we have a study that shows IV acetaminophen works better, kind of thing. Here's a study, IV versus PO. And this is in male adults, but here's an example of how you cheat in medical literature. This is the graph that they showed, showing that IV was superior to oral. Oh, that looks like a big, huge difference. But if you could read the ranking on the side, the numbers on the side of the graph, you would see that the height, the biggest difference is 0.3 millimeters, 0.3 Fahrenheit or centigrade. Hardly any difference of any clinical significance. But if you have the left-hand column where the differences in degrees are really large in terms of the spacing, you can visually make something look important when in fact clinically it is not. And this is done here, bottom study. Here's another study from India where basically they showed IV versus PO. There's no clinical difference here. Yes, the graphs do look different, but they are misleading in that process. So vaccines are really what it's about. Martha talked about that a little bit. Look at this, 4,000 cases of bacterial meningitis a year, 4,000. And who all did this? The immunologists. They basically made these diseases kind of go away, particularly when they went after one bug in particular and nailed it. Here's a great example, too, of the average age of meningitis is 42. Well, that's kind of interesting. Well, the fact that's really not true, because the people who get meningitis still are kids and the elderly. Kids and the elderly. Kids in the elderly, the average is 42. Nobody gets it at 42. It's just a mathematical trick that says, and the kids in the elderly, 42. Here's what it's about. This is what the immunologists did. So the 7-valent pneumococcal vaccine, which was causing strep pneumonia and meningitis, which is by far the worst meningitis you can get in day-to-day meningitis, in terms of neurologic outcomes, those kinds of things. Look what happened in the third on the left. That's with 7-valent, in terms of decreasing pneumococcal. Then they came out with the 13-valent, which is the red arrow on the right, and it made it go away. These disorders now are really, really uncommon. Pediatric meningitis, really uncommon. So I'm wondering, you know, when we see doctors coming out of their training, or you or your PA/NP colleagues, how many lumbar punctures have you done in a 3-month-old? How comfortable do you feel doing a lumbar puncture in a three-month-old? Because the fact is, this is a rare disorder now. It wasn't when I was younger. These vaccines all came out after I did. So the immunologists basically have put the kibosh on the bad guys. H. influenza type B, which was the cause of bad infections, bacteremias, and the like. So our job now is to find the source of the fever. We have a fever, let's find the source. We have the detective here. And we're looking for treatable sources of fever. We're not going to cover kids who are 3 months and less, because that's really a much more complicated. I'm interested in three months to 36 months, 3 years. And that's kind of one of the age ranges that the American Academy of Pediatrics has made some recommendations about. So that's what now this one basically tells you about how to go through this process. This is from the American Academy of Family Physicians, and I think it's blown up in your book. And I'm not going to go through the specifics of it, but you may want to take a look at this on the plane on the way home in terms of an algorithm for working up febrile kids. But for us, there's 2 things that we're looking for. The things that are treatable, that are most common by far, are urinary tract infections and pneumonia as the cause of fever. You can also have a strep throat, maybe. Well, that doesn't occur in kids under 3 for all practical purposes, so that you can look for that. Strep throat, I guess, can cause a fever. But we're looking for really source unknown fevers kind of thing. So we don't find any cellulitis. We took the kids' clothes off. We got a good look. There doesn't seem to be anything. I looked in the throat. That looks okay. That's not the source of the fever. I looked in the ear, and that's not the source of the fever. And frankly, even if they had a rip-roaring ear infection, that wouldn't be the source of the fever either. It is believed by us for many, many, many years that kid comes in with a fever, and I look in the ear. Now, I know there was a talk on ear infections given, and I'm basically going to kind of go a little rogue here and say that ear infections don't cause fever. Ear infection is a little tiny abscess behind the eardrum. That's it. You know of abscesses that cause fevers? You've all seen big abscesses all over the place. Do they cause fevers? No. What's so special about this one that you're allowed to have 103 fever caused by this? So that you looked in the ear, there was ears a little red. Aha, Ma, I found the problem. No, you honestly haven't. Yeah, there's an ear infection, but the cause of this fever is this viremia that this child has. And when you have a 5-year-old who comes in with an ear infection, and they're crying and they're holding their ear, and you look in there and it's flaming red, that child's afebrile. They're in there for an isolated. It's killing me. And think about it. How many of those 5-year-olds have a fever? They don't. So now we're willing to blame this 103 in this kid. So, and I can show you 5 major journal articles, reputable, big places, Massachusetts General, where they were looking for what is the cause of this source unknown fever, and coming up with an algorithm. And they took kids into these trials, but sources unknown fever, and they included in those trials kids who had ear infections. And when you include in those trials kids who have ear infections, what that says is that is not the source of the fever. We got to keep looking. And that is the case for you too. Now that's an upsetting kind of thing, but I have something that's going to save you, because instead of blaming everything on an ear infection, there's always one ear that's a little bit redder than when you need it, you'll find that ear infection. I know you will. So don't use that excuse anymore. I'll give you another one in a minute. So we're looking for urinary tract infection. For febrile kids, they say that 1 in 20 will have the infection in the urine. That's what the AAP says. 1 in 20, 5% will have a urine infection and a source unknown fever. So bottom line is that source unknown fever, you got to look at the urine. Now, they say 1 in 20. What they don't say is, what is the background rate of bacteria in the urine? We know in adults there's a thing called asymptomatic bacteriuria. We acknowledge that's and we're not supposed to treat that with antibiotics, and that's basically largely women who have some pus in their urine, but they have no symptoms whatsoever. It's just asymptomatic bacteriuria. Does asymptomatic bacteriuria, is that allowed to exist in little girls? What's the incidence of asymptomatic bacteria in little girls? It's between 1 and 3%. So if you take a study of kids who are going to have some operation and have their tonsils out or something like that, and you get the parents to agree that we're doing a study, we'd like to do a cath urine on your little girl before she's put to sleep or after she's put to sleep to see what's in the urine, and this perfectly otherwise well child who's having an elective operation, 1 to 3% of them will have signs of a urine infection without any signs of a urine infection. So that little kids are allowed to have asymptomatic bacteria, just like the whole rest of the world is like to have it. So is it 1 in 20 that has a urine infection? And it's not a urine infection. This is pyelonephritis. What in urine infection we generally call UTI. No, we don't. UTI is the big catchword, but we have a lower infection, which we call cystitis, bladder infection. We have upper tract infection, which we call pyelo. Pyelo causes fever. This bladder infection doesn't. This must be pyelo. If it's pyelo, then we may have a kind of a serious condition on our hands. So this 5%, I think, needs to be kind of put into context of, is it really 5%? Is it, or maybe 2 or 3% when we realize the asymptomatic bacteriuria rate? So we're working up with this kid, and we're going to get a urine, and if the kid makes a urine, great. And but we have to be kind of aggressive in terms of what to culture or not. Don't even think of sending a bag of urine don't ever think of that. Bag of urine is good for some things, and it's good here. So trying to get a kid to pee. This kid is obviously an infant, and we're not talking about infants, but this thing works. The older the kid works, the less it works. But I have named this the chicken technique. Now, it is not named the chicken technique in any of the studies that refer to this, because they use more professional terms, but I call it the chicken technique. So what you do is you grab the chicken underneath the arms. That's one person's job, is to hold the kid up. And then you get another person to rub the lumbar area. Is it clockwise or counterclockwise motion? Depends if you're in the northern or southern hemisphere. And then you have another guy tap the bladder at a rate of 100 per minute. So you now have 3 persons, and then you have the most important person, the catcher. So this is a 4-person job. Shut down the emergency department. We're getting a urine on this kid, and in comes, and look at this, 69 of 80 peed within 5 minutes. 69 of 80 peed within 5 minutes. And there's 2 studies there. There's not just one. There's 2. And yes, the older the kid, the less likely it is to work. But you say, well, this is not a sterile urine. Some of you work at some places where the only way that you get urine is by cathing these little girls, particularly. And I don't want you to raise your hand, because you shouldn't ought be doing that. And most places who do it are the children's hospitals, for crying out loud, people who really ought to know better. So basically, once you get this urine, you dip it. If you are allowed to dip it in the emergency department, and you put it in a machine that reads it. Before the old days, we used to hold it up and read it. You're not allowed to do that anymore. You have to put a machine in there. There's a little guy in there typing. It gives you the report that comes out for the dip urines. And if it's nitrite positive, this kid has a urine infection. Nitrite positive is highly specific for an infection, because this means that the E. coli have taken the nitrates in the urine and tainted to the nitrate, and it makes it stick positive. So that would be a first one. If you feel real good if the nitrates are positive. Leukocyte esterase is a little less specific, for sure. So if I had my choice, man, I would take, nitrate positive, absolutely. Well, nitrates negative may not mean that the urine has not been in the bladder long enough. Ideally, it would be great if you could take the first urine in the morning. The urine has been sitting there all night, bacteria is working on it, etc. That's kind of a true with women as well. We'd like to get as concentrated a urine as possible. But that's what you do. And here are risk factors. In American Academy of Pediatrics, in this journal article, which is referenced in a slide or two, comes back with risk factors. You will not remember these risk factors. But it's always important to stratify low risk, high risk. Are they low risk, high risk for meningitis, low risk, high risk for UTI, pneumonia, those kinds of things? So they have risk factors in boys and girls. I'll show you something that will get you to risk factors really easily on your telephone. And if a kid's low risk, they can go home, because then we're looking for 1 in 20. But now when we stratify and the kid's low risk, let them go home. If they're not feeling better in a couple of days, bring them back. If the kid's not low risk, we have a couple options. One of them is to cath them, culture them, get a urine, and if the urine's positive, treat them. And if the urine's negative, you've still got a culture pending, then you can kind of do nothing. But then the other option is the one I like, which is basically do the chicken method, get the urine. If the urine's negative for leukocyte esterase nitrates and has less than 5 WBCs, you're done. Send them home. Here's what you need. This is from the University of Pittsburgh. They did a study that came up with a risk stratifier, which they derived and then subsequently validated, and they made a program out of it. This program is based on this study out of the JAMA Pediatrics. 618 is new, relatively. So get this. This will help you stratify. And so when you can say in your chart, low risk per University of Pittsburgh guidelines, which is what they're talking about here, it helps defend you because now you're making decisions with somebody supporting you. Initial treatment is equally effective orally or IV? Yeah, that's true. If you're not vomiting, all this stuff is concentrated in the kidneys. We're going to be, all these kids who basically have fevers have pyelo. We're sending pylos home with oral antibiotics. So why do they need IV? Well, if they're sick, they're not holding things, they're dehydrated, those kinds of things. Yes, we'll do it IV. But everybody else who's got pyelo is going to get an oral antibiotic, and there you go. If you're going to give a shot, they basically say ceftriaxone, 75 milligrams per kilogram. That lasts 24 hours. If you're going to give orally, which is by far the most common, you're going to give something that you can give once or twice a day. The only one that they recommend once a day is Suprax, which is cifixine, but it's expensive. Suprax is expensive. Bactrim is cheap, and that's twice a day. And every other antibiotic that they recommend is twice a day, so you might as well pick Bactrim. Now, the question is, if you miss these urine infections, are these kids going to be on dialysis? Well, how many kids do you know basically over their lifetime got into trouble and went on dialysis? These guys try to make this case. They say, well, if you have pyelonephritis and you miss it, these kidneys are going to be all scarred up and they're going to be dysfunctional and they're going to be on dialysis next thing you know. These guys looked at 10 journal articles about specifically that, and they looked at all of their own personal experience at their institution, and they said, at best, some issues regarding renal function would be, and I can't even agree with these numbers. This would be the worst case scenario. So that's 2 per 1,000. But we don't miss the urine infections because, they used to be called otitis media, and they were treated, and people got well. But when you treat these kids, if they're being treated for a urine infection, they need to be treated for like 10-day kind of thing. The other thing is pneumonia. That's number 2. Infectious Disease Society in America and the IDSAs and the Pediatric Infectious Disease Society have come up with some recommendations. I love this, 2011. This is the official recommendations of these organizations. Yeah, who to admit? Well, you know who to admit kind of thing. It's kind of nothing special there. Testing. Don't do blood cultures unless they're toxic looking. And the same is true for urine infections. If you have an adult with a pyelo in the emergency department and they've got a fever and flank pain and you're going to give them some ceftriaxone, don't do blood cultures. It's a total waste of time. The literature says it's a total waste of time, but it's kind of like, well, you didn't do blood cultures? What's kind of, where'd you get your license? Pep Boys or something like that? No. The bug is in the urine. This culture the urine. It doesn't matter if there's bugs in the blood. It doesn't change what you're going to do in terms of what antibiotic or how long you antibiotic. So it doesn't matter if you have bugs in the blood when you have pyelo. Yeah, they said if they're sick, you can get a sputum gram stain, but that's kind of marginal recommendations. Let's get down to the most important ones. You can test for flu if it's flu season. Yeah, test for flu. But they say if you test for flu and the kid's pretty sick, then what if it's a false negative test? So they give the medicine anyway. If it's flu season and the kid's sick and you're concerned, even if the flu test is negative. Mycoplasma tests are, like cold agglutins, those kinds of things. We'll talk about what is the characteristic of mycoplasma. But the most important thing to hear on this slide is your new gift. This is a gift from the Infectious Disease Society and the Pediatric Infectious Disease Group. It says, a chest x-ray is not necessary for the confirmation of suspected community-acquired pneumonia in those treated as outpatients. Have you ever seen that in your entire life? That is from these two societies. You don't need a chest x-ray to diagnose any pneumonia anymore. There you go. That's your go home, pass go, give antibiotics whenever you want now. Don't blame it on an ear infection. I think you may have a little pneumonia. I don't need an X-ray. It says right there I don't. It's clinical diagnosis. Since when? But anyway, that's what they say. Here's your amoxicillin. Thank you. Goodbye. This is a gift. This is a little blurry, but basically kind of differentiates atypicals, mycoplasma. More virally like. So here's the, perihilar, diffuse, fluffy kind of thing. Those are generally the viral ones, or the mycoplasma ones. And the nice lobar ones, that's the strep pneumoniae, pneumococcal ones. And, you can see a nice right upper lobe in the middle one there. More fluffy, perihilar, the viral. Viral. Somebody's got a situs inversus there of the heart. So who do you treat? We treat school-age kids who you think have pneumonia. They said you don't have to treat them because it's generally viral. And if you do want to treat them, they get amoxicillin. That's it, amoxicillin. Nothing more sophisticated than good old amoxicillin. School-age kid who you think has pneumonia, but they say you don't need to do it. The language is pretty specific. Once you hit school age, 6 and 7 and older, they become like adults, where they basically kind of need a drug that is effective against not only strep, but the mycoplasma, those kind of guys. So they would be the erythromycin kind of guys once they're in school. And they're very liberal about antivirals. If you have pneumonia and you're pretty sick and your viral test is negative, that's fine. They still want. There's these people who basically, and it was mentioned before, the idea that people have bad outcomes who have pneumonia, and it's like, well, didn't you give the antiviral kind of thing? Is it going to hurt them? Not really. I think Martha did that. Inpatients are ceftriaxone and just like in adults. This is American Academy of Pediatrics. I think that this is made big on your books. This is all you need to know about pediatric pneumonia. It's on basically 2 pages. If you get 90% of that in your head, that's it. That's all you need to know. Or if you post this on some place in your department, that's all you need to know about peds pneumonia, which is generally kind of like a big category of illnesses that we're concerned about. Peds pneumonia, peds UTIs. We talked about strep throat. We talked about ear infections as common sources of fever, but the vast majority are going to be viral because the immunologists have done such a terrific job of getting rid of the bad bugs. H. influenza type B, and by far strep pneumoniae was the bad player.